Hey everyone, I know we've talked about this before, but I'm going to do a quick refresher. I know it does say Unit 4, but we are covering this in Unit 7. I will be talking about suicide and non-suicidal behavior, and there will be some sensitive topics discussed at this time. So we have a few different terms. Suicidal ideation, thinking about death, right? Wishing to be death. Everyone would be better off without me. If I wasn't here, if I just were to crash my car into a tree. Suicide is the intentional act of killing oneself. A suicide attempt is carrying out that act with an intent of death. Maybe something happened, maybe it was interrupted, maybe it just all sorts of things could happen. And then the completed suicide is the phrase that we use when that act results in death. So when we look at epidemiology, there is a ton. Kaylin put Kentucky because we are school headquarters in Kentucky. However, it is the 10th leading cause of death. In 2019, we had one completed suicide in the U.S. every 11 minutes. These numbers are often underreported, so we don't know. We do talk about the military is increasingly concerned about suicide rates. However, I always do like to bring in healthcare providers. Especially in the last few years, we are seeing increasing rates of suicide in healthcare providers. So just because someone is in a white collar, good profession does not mean we should discount that. I did pull in, this is from Department of Health and Human Services for Texas, some data from Texas. So when we look at mortality rates, crew death rate, different things, we can see how it was changing. Adults 50 to 54 was 38.1, and it increased between 2000, my numbers, 2000 and 2022 from 12.6 deaths per 100,000 to 17.4. Children, again, low, 2 deaths per 100,000 in 2020, 2.7 deaths per 100,000 in 2020. However, that should just not be happening. So we are seeing increases in suicide rates. Risk factors. We have talked about suicide quite frequently throughout the quarter. Previous attempt of suicide, one of the suicide screenings we'll look at in class is a CSSRS, and it kind of gives credit for high risk to anyone with a previous suicide attempt, but it is a higher risk if that previous suicide attempt was in the last 3 months. History of suicide in the family, especially in that first degree relative. Substance abuse, substance use, impulsivity tends to be increased in those who are using substances. Or mood disorder, so depression and bipolar. And not always just in that depression phase of bipolar, but it could also be during that manic phase. Access to lethal means. Statistics is about a year old, but the last I checked about a year ago, 55% of suicides in America were completed by a firearm. So if our patients have access to a firearm especially. History of trauma or abuse and professionals. We again don't always think about professionals. Dentists, air traffic controllers, healthcare providers. Whole bunch that we can look at. Losses, breakups, deaths, changes, academic failures, financial difficulties, physical illness, terminal illness, chronic pain, exposure to the suicide behavior of others, especially when we look at adolescents, high school age kids. It's tend to refer to as like a suicide cluster, where if someone in a location has committed recently suicide, we tend to see an increase. And these are not even all of the risk factors. We're going to talk about personality disorders coming up, borderline personality disorder, recently starting an antidepressant, discharge from a psychiatric facility, lack of access to health care, men, especially over the age of 65, and especially white men. I think it's white men account for 70% of suicides in America. I think we're trying to remember the statistics from your textbook, but it's a very high number. We can keep talking about kind of risk factors for veterans. Just so many different ones. Warning factors are things that we kind of see going on that should alert us to some type of change. So talking about death, writing about death or suicide, as the person writing and crumbling up and rewriting a suicide note. Hopelessness, worthlessness, feeling like there's no escape, that trapped burden on others, especially if we're talking about maybe chronic illnesses. No reasons for living. When I started working, oh my gosh, over a decade ago, at one of our psych facilities I was at, before we had the standardized assessments, one of the questions we would ask is, do you have more reasons for living or do you have more reasons for dying? And that was, I loved that question because it did, especially with our patients, start a lot of really good conversations. Increases in alcohol or drug use, withdrawing from friends, community, and that sudden mood change. One of the things we have to remember, that sudden mood change does not always have to be negative. If we have someone who has been very depressed, right? They get admitted to the psych unit, they're super down, depressed, no energy, and they are, suicidal. And we start them on meds, and 2 days later, they're like, I'm so much better. Everything's going to be okay. That sudden mood change to a positive should be a huge red flag. Because oftentimes that sudden move to a positive is a sense of relief. This patient has made a decision about how and when they will end their life. So it is very much a warning sign for impending. You're not going to get better from antidepressants in 2 days. The situation is not going to resolve itself in a few days. So dramatic mood change to the positive is a warning sign. So protective factors, effective mental health care. Do you have a provider who you can see, where it's easy, regular access to appointments? Strong connections. Strong connections and religions oftentimes go hand in hand. Do you volunteer? Are you part of a church group? Do you have the ability to problem solve? Some religions, when we talk about religions, one, it's because religions often come with a community, so it provides a connection. But also when we look at religions, some are very much, strict laws or rules, depending on the different religion. We're going to use different words against suicide. And there are some people, just because of what their religion says about suicide, they will not consider it as an option. So when we're assessing, we need to almost like rearrange some of these questions. The first thing we are going to assess for is, are you having thoughts? So first, are you having thoughts of suicide? Do you want to kill yourself? After we assess that, are you having thoughts of suicide? Do you want to kill yourself? Then we're going to assess a plan. Do you have a plan? So first, do you want to kill yourself? Second, do you have a plan? When we assess plan, that is when we are going to go over into this history. So 1, do you want to die? And this kind of order is important. This is jumbled. First is, do you want to kill yourself? Are you having thoughts of suicide? Second is, do you have a plan? And I know my handwriting is really bad. When we look at plan, we have to kind of look at intent. And we have to look at also means. Does the person have access to their means? So if I have a patient who wants to jump in front of a train, but they're locked on a psych unit, I'm not too concerned about those means. If I have a patient who is on a psych unit and they told me they're going to kill themselves, and when I asked their plan, they say they're going to slit their wrist with a razor blade, do I trust that they did not sneak in a razor blade? Access to means is a huge red flag that we have to look at. I am trying to erase all these, and we know this is not going to work today because now I've somehow got a highlighter on. So do you have a plan? Do you have access, and do you have means to whatever that plan then was, are going to our biggest red flag. After that, we can go into the risk factors. Then we can go into the protective factors. Then we can go into support system, coping skills, stress. So we can see I've added in some of our suicide screens. This is the Ask Suicide Risk Rating Tools. Do you wish to be dead? Right? Have you been better off? Are you having thoughts of killing yourself right now? Yes, the patient answers yes, especially to question number 5. we're going to put them on a one-to-one. We're going to have to keep evaluating this. This is the CSSRS. This is what HCA uses. This is what most of our facilities in the area. So again, have you wished to be dead? Are you having thoughts at this moment? Right? Do you have a plan, like specific plan? Do you have a method? Is there intent? Do they intend to carry it out? Is it, I've been thinking about it, but I don't intend to? I know there's a whole lot of different things we can look at. We follow through these. If any of these red boxes are checked, it is a high risk. Any of the orange boxes, it is a medium. Yellow boxes are low. Again, though, if we have one red box, even if the whole rest of them are yellow, that does make you a high risk. This is from some of the longer of the CSSRS where we talk about what's been going on, risk and protective factors that we've been seeing in our patients. The top are a lot of the risk factors, the bottom are a lot of the protective factors. So in our assessment, verbal, nonverbal cues. Direct, I'm going to blow my brains out. If a patient tells you that, right, I'm going to go and shoot myself. We're not going to second guess what they're going to say. In that indirect statement, my family would be better off if I weren't here. That is when we have to use a lot of that clarification. When you say this, what do you mean? Again, those non-verbal. If all of a sudden someone's double checking their will and making sure their life insurance is in order, giving away their favorite objects, right? That sudden brightening of mood. We would then want to ask if I saw that, hey, are you having thoughts of wanting to kill yourself? Directly ask. So again, when we look at the plan, all threats of suicide are taken seriously. When I worked pediatrics, if I had a kid who said they were going to kill themselves by banging their head on the wall, probably not likely going to happen. However, I still would take that seriously. Lethality, we do have what's called hard or soft. Hard, high likelihood that death will come. Soft, soft is not as lethal. We talked about means, especially that access. If you have access to proposed method, that is more serious. If the person has to go and get something, that is not as concerning as the person who has it. Because if I'm going to have to get in my car and drive to the store and do this, this, and this to get my means, that is not as concerning, right? Because a lot of that impulsivity with suicide. We always prioritize patients with plans and means. Our nursing diagnosis and mental health with the highest priority is risk for suicide. Primary prevention is the biggest thing we have to do. So decrease the stigma, training classes, education, mental health first aid for everyone. In that moment with this patient, safety, we go on a one-to-one. We will ask the patient to fill out a safety plan, or we should. This is an example of one. Your textbook has a few other different examples. Usually there are a bunch of different things we committed. Who can I call? What are some warning signs? In class, I'm going to hand out a different version of it. So we have a bunch. Reaching out, social supports, 988 as a suicide hotline are extremely important in this. We have a whole bunch of resources. Here, National Suicide Prevention Hotline has been updated 988, not this number. When we also talk about keeping these patients safe, so we have to think, and I know most of y'all have been in clinicals, some of that unit design, jump-proof windows, right? We're always make sure windows are locked. Doors to bedrooms should always be open and unlocked. All other doors, nursing stations, laundry rooms, offices should always be locked. Shower curtains will be Velcro. We'll have the faucets and different things in the bathroom that are recessed so they are not hanging out, right? The doorknobs are slant proof so that you cannot hang yourself in a doorknob. We're going to search the patients, take away sharp objects, shoelaces. We were actually just talking to one of the staff members at clinical yesterday, and they were talking about how they were searching. They had gotten permission for one of the pediatric patients to have a stuffed animal, but they were super in-depth searching because the patient had once had like a whole bottle worth of pills hidden inside of this bottle. So we do have to take that into consideration when we're talking about medications. We list medications, but I honestly would not even remember any of these because it's basically we are treating whatever that underlying condition is. Our interventions are going to be focused on postvention. So primary prevention education beforehand, secondary prevention screenings. Anytime you go into primary care, where you go into your doctor, we're doing that PHQ-9, we're asking those questions. Tertiary care for suicide is postvention. It is focused on the survivors. There is a lot of guilt. There is a lot of shame that you can go on. In class, we'll watch a little bit of a video if we have time about Naomi Judd. She died by suicide in 2022, and her husband after the fact said, when you lose someone to suicide, you don't get a chance to say bye. It was a pain that I've never felt before. We have to focus on the survivors, on the family members. A lot of the talk about thoughts and feelings, not necessarily on that deceased individual. As we talk about any death, loss, and grief, it is not always in that time that it is difficult. Often the hardest time is in the months after. The first, Christmas, Mother's Day, a birthday. Because of the stigma associated with suicide, oftentimes when someone does lose a loved one to suicide, no one's really checking in on them. No one really talks about it. So making sure that individuals are checking in, referring to community resources, grief groups, are just a few of the things that we can do for those family members and loved ones. Non-suicidal self-injury is a little bit different. These are deliberate, direct attempts to cause an injury, but there is not an intent to end one's life. A few examples: cutting, burning, scratching, scraping, screwing nails into themselves, banging their heads against the wall, hitting themselves. We could keep listing types for a while. Again, we are making some generalizations. There are many reasons that this could happen. However, if someone has a lot of psychological pain, causing this injury allows them to focus on physical pain, not psychological. If there is no psychological feeling, if they are numb, this allows them to feel something. It can, again, we don't always want to say, but it can be attention seeking. They could be avoiding a situation, trying to get out of something. It could be done to relieve anxiety. It could be done as self-punishment. So we do have a bunch of different reasons why. It does often occur with other mental health disorders, mostly in our adolescents and young adults, and then it kind of drops off. If we have a peer who is engaging in non-suicidal self-injury, just very much like our suicide clusters, we are more likely to see that in others. Very much like a pain assessment, most of our psych assessments. So if I do have someone who is having non-suicidal self-injury, I need to make sure I'm looking at the self. What are they doing? Why are they doing it? When are they doing it? How are they doing it? And again, these are medical if we're looking at wounds, so we always have to prioritize infection and making sure the wound is healing. Boundaries, we talk about this a lot this quarter. Very matter-of-factly, avoid that transference and countertransference. Depending on what is going on with your patient and where they could have scars, let's say maybe even if you're in a medical setting and you're treating a patient and you notice they have a lot of scars, we have to be very matter-of-fact. We don't want to increase the shame and doubt and stigma in this patient when we see this. I'm going to skip the video, and that is it. We'll go through a bunch of questions in class, but if you have any questions, please let me know.